Asthma drugs. So first of all, what is asthma? Asthma is a reversible obstruction in the airway. It happens when there is inflammation in the airway. So the mechanism of asthma, or the pathology of asthma, is first there is a contraction of bronchial smooth muscle. Then there will be a bronchoconstriction. Then afterwards, when there is a bronchoconstriction, an inflammation of bronchial wall will happen. Therefore, I think even the mucus lining thickens or something, then therefore creates an airflow obstruction. So what are the trigger points, or what triggers asthma? First, we have the allergens: cold air, exercise, drugs, respiratory infections, and stress. So when we say allergens are what triggers your allergy. So what is allergy? Allergy is like exposure to allergens. So examples of allergens are animal fur, pollen, dust, smoke, and etc. So upon exposure to allergens, it triggers the IgE, or it triggers your IgE, which is responsible for your immune system, I suppose, or your allergy reaction. Then the IgE binds to the granulated mast cells. Then afterwards, when the IgE binded to the granulated mast cell, it results to acute bronchoconstriction. Then afterwards, early asthmatic response. So first, exposure to allergens, then it triggers your antibody IgE, then the IgE binds to your granulated mast cells, then there's an acute bronchoconstriction, then early asthmatic response happens. So another effect of asthma is anaphylaxis. So there are different effects of anaphylaxis in different parts of the body. So for CNS, or the central nervous system, it's lightheadedness, loss of consciousness, confusion, headache, anxiety. Then for the cardiovascular, it's fast or slow wing of heart rate and low blood pressure. For the gastrointestinal tract, it's cramps, diarrhea, vomiting. For the respiratory, it's the shortness of breath, acronym, I think it's the SOB, wheezing, hoarseness of voice, pain in swallowing or cough, because it's usually the throat or the airways that are swelling, because in anaphylaxis, swelling of the lips and the tongue and other parts of the body happens also, aside from runny nose and pelvic pain. So the manifestation of anaphylaxis in the skin are hives, itchiness, and redness, pruritus. And also when you're under anaphylaxis or anaphylactic shock or whatever, you also lose bladder control. So we're now down to the treatment of asthma. So there are two categories of drugs for asthma. One is the reliever, or first is the relievers, or also called the bronchodilators, and the second one is the controllers, used for long-term treatment of asthma. So for the relievers, it is used for acute asthma symptoms, as in you need, kailangan, ngayon na, ganun. So under the relievers, sympathomimetics, we also have the non-selective sympathomimetics, non-selective alpha-beta blockers, and the selective alpha-beta blockers. Usually it's a beta-2 agonist, something. Then we also have the methylxanthines and the anticholinergics. So for the relievers, the first line drug for the treatment of acute asthma symptoms is inhalational SABA, or inhalational short-acting beta-2 agonist. Then the second line, or the second option, is the oral SABA. It is because inhalation has a higher bioavailability of the product itself. So when you take the oral SABA, it takes longer time before it takes effect than the inhalational. The inhalational does not undergo the normal process of biochemistry. Yeah. What do you call it? Ladmer. Yun. So yun. So under controllers naman, for the long-term treatment of asthma, it lowers the risk of asthma attack. So first, under the controllers is anti-inflammatory agents, or the corticosteroids, the anti-IgE, the mast cell stabilizers. Then secondly, the leukotriene pathway inhibitor. Let's see. Leukotriene pathway inhibitors, we have two types, the LOX inhibitor and the receptor inhibitor, leukotriene receptor inhibitor. Then the LABA, or the long-acting beta-2 agonist. So for the controllers, we have the first line is the inhalational LABA, inhalational long-acting beta-2 agonist. And second line is the oral corticosteroids. So before we know what kind of drug we should give the patient, if you're a doctor, you also need to know the classifications of asthma. So there are 4 classifications of asthma. It's the mild intermittent, mild persistent, moderate persistent, and severe persistent. So under mild intermittent, how do I know it is mild intermittent? So kapag mild intermittent, kapag daytime attack is less than 2 days a week na hindi magkasunod. Tapos kapag nighttime naman, less than 2 nights a month, dapat hindi rin magkasunod. So yung treatment for mild intermittent asthma is also beta-2 agonist. So the second classification is the mild persistent asthma. So during daytime, we have more than 2 days a week, but not daily. Then nighttime, 2 nights, more than 2 nights a month. So ang difference ng nila, intermittent, less than 2 days, less than 2 nights. Ang mild persistent, more than 2 days, then more than 2 nights. Tapos, tapos, we have 2 treatments for mild persistent asthma. So, if we use the relievers, it's the beta-2 agonist. Then, kapag controllers naman, a low-dose inhalation corticosteroids, kasi corticosteroids are anti-inflammatory, I think. Yeah. Anti-inflammatory, under controllers. O, tama. Anti-inflammatory under controllers. Baka kasi mamaya mali yung pinagsasabi ko. Mali din yung masagot ko sa exam. So, third classification is moderate persistent. So, moderate persistent, persistent na nga siya, diba? So, parang daily, regular, ganun. So, moderate persistent, medyo madalas na. And dahil moderate, daily but not more than once a day. So, everyday siya, pero dapat hindi siya lalagpas sa once a day. Tapos, night attack is more than 1 night per week. So, magiging na siyang weekly, mga 2 times a week, ganun, 3 times a week. So, ang treatment din doon is pag sa relievers, pag yung biglaan ganun, beta-2 agonist, always. Tapos, kapag controllers, inhalational glucocortisol or glucocorticosteroid and long-acting inhalational beta-2 agonist. Kailangan yung laba na inhalational. Tapos, kapag severe persistent, ito yung mga laging inaatake ng asthma. Kapag daytime attack, it's more than once a day, every day, more than once a day, every day. Tapos, night attack, it's every night. Tapos, ang drug nila for severe persistent, again, beta-2 agonist na injectable or inhalational. Then, kapag yung controllers, high dose na ng inhalational glucocorticosteroid and inhalational na LABA. So, under relievers, yung mga bronchodilators, di ba we have different parang categories under relievers. So, first is sympathomimetics. So, yung mga selective sympathomimetics is yung mga short-acting beta-2 agonist. It is widely used, kaya yung mga narinig nyo kanina treatment, halos lahat merong beta-2 agonist kasi sila yung parang first-line defense for asthma. So, under SABA, it's ATM, yung acronym. So, it's albuterol, terbutaline, and metaproterenol. Metaproterenol. So, albuterol, terbutaline, and metaproterenol. Metaproterenol. Yung mechanism of action ng SABA or short-acting beta-2 agonist is ini-increase niya yung intracellular levels of CAMP or CAMP para magkaroon ng bronchodilation. So, SABA is used for, or the DOC for acute or mild asthma. So, yung mild intermittent asthma at saka mild persistent asthma, ito talaga yung parang pinaka-DOC niya. Tapos, second category ni sympathomimetics is the non-selective agonist. So, pwede siyang maging alpha or beta agonist. So, andyan si ephedrine, epinephrine, tsaka isoproterenol. So, si ephedrine, tsaka si epinephrine, halos same sila ng effect. Yun nga lang, si ephedrine, longer yung duration of action niya, but lower potency than epinephrine. Si epinephrine naman, siya yung drug of choice for anaphylaxis, at tsaka rapid-acting siya na non-selective beta and alpha agonist. Tapos, si isoproterenol, 60 to 90 minutes duration of action niya. Tapos, siya yung pinaka-nagbibigay ng bronchodilation kasi within 5 minutes magkakaroon na siya ng effect. Beta-1 and beta-2 agonist siya. So, non-selective kasi both beta-1 and beta-2 nag-act siya. Kaso, dito sa mga non-selective beta agonist or sa non-selective agonist, ang toxicity nila is tachycardia, arrhythmia, and worsening of anaphylaxis. Kasi nga, non-selective sila. So, tinatarget nila yung iba din mga receptors. So, yun. So, dun lang sa terbutaline, dun sa kanina sa SABA, ang off-label niyang effect or use is tocolytic or oxytoxic, pampakapit. So, tocolytic, tama ba? Tuko, or, sabi ng prof namin, tocolytic or tuko, kasi pampakapit, mas makapit. Ayun. So, next. Sa relievers pa rin, bronchodilators, dun na tayo sa pangatlo. Next time, meron na akong board chart. Joke lang. Sa relievers pa rin, di ba yung second, yung first is the beta agonist. Non-selective tsaka selective. Tapos, yung second na category ng relievers or bronchodilators is methylxanthines. These are also weak diuretics. So, under methylxanthines, meron tatlo. So, theophylline, aminophylline, tsaka caffeine. Ang tatandaan dun sa tatlo, kasi yung parang chemical name nila, si theophylline is tsaa. T, 1,3. So, isang tsaa, 1T, dimethylxanthine. Tapos si aminophylline is COCWA, 3,7 dimethylxanthine. Wala akong naisip doon na parang palatandaan. Pero si caffeine, siya yung kakaiba sa kanilang tatlo. Kasi, di ba, kapag coffee, usually 3-in-1 yung iniinom natin. So, 1, 3, 7, trimethylsaline kasi tatlo. So, si aminophylline is also called as salt of theophylline. Tapos, si theophylline naman, siya yung treatment for nocturnal asthma or nocturnal attack of asthma. So, yung mechanism of action nila, ini-inhibit nila yung PDE para ma-increase yung CAMP, therefore, nag-increase yung bronchodilation. Kaya siya under ng relievers or bronchodilators. So, doon na tayo sa pangatlo, diba? Madalis lang yung methylsaline, basta si tea, cocoa, and caffeine. Tapos, si muscarinic antagonist or anticholinergics, yung pangatlong category ng mga relievers. So, si muscarinic antagonist or anticholinergics, mayroon dalawa na main drugs. So, si ipratropium bromide and tiotropium. So, si ipratropium bromide has least effect. Tapos, si tiotropium naman is longer acting for COPD naman, chronic obstructive pulmonary disease. So, ang mechanism of action nila, binablock ni muscarinic antagonist or anticholinergic ang effect ni acetylcholine. Tapos, nangyayari, binablock niya yung acetylcholine sa muscarinic receptor sa airways. Kaya nagkakaroon ng bronchoconstriction. Ay, bakit bronchoconstriction? Hindi ko din alam. Yun lang yung sabi ng prof namin. Pero babasahin ko ulit. So, ang muscarinic antagonist or anticholinergic, it is designed for inhalations. Chronic obstructive pulmonary disease. Alam ko na, bronchoconstriction kasi kinoconstrict niya yung pag-uubo mo. So, ititigil niya yung ubo mo. Yata. Correct me, please. So, yung toxicity ni muscarinic antagonist or anticholinergics is xerostomia, or dry mouth, and bitter taste. Di ba kapag yung inhalations, parang lasa niya. Parang kumain ng Splenda, pero yung Splenda, matamis sa una, tapos aftertaste na, bitter na. So, yun yung hanggang relievers. Next na lang natin yung controllers. Mag-charge muna ako. So, next are the controllers. It is for long-term treatment of asthma. So, under controllers, we have anti-inflammatory agents or anti-inflammatory drugs, which includes corticosteroids, the anti-IgE, and mast cell stabilizers. So, under anti-inflammatory agents or under corticosteroids, we have the inhaled corticosteroids, systemic corticosteroids, or the parenteral corticosteroids, parenteral steroids, and the systemic oral steroids. So, what is the mechanism of action? Ano bang ginagawa ng corticosteroids? So, ang corticosteroids, ini-inhibit niya yung release ng arachidonic acid through inhibition of phospholipase A2, which, therefore, blocks leukotrienes na ang ginagawa or ang nangyayari after that is nagpaproduce sila ng anti-inflammatory effect sa airways. So, yung diniscuss namin ng prof namin yun, in-explain niya muna yung pathway ng anti-inflammatory. So, ang tinatarget ng anti-inflammatory is yung leukotrienes. Actually, dahil ini-inhibit niya yung arachidonic acid by inhibiting phospholipase A2, yung enzyme na yun, kaya nagbablock siya ng leukotrienes. Kaya nagkakaroon ng anti-inflammatory, specifically sa airways. So, ang corticosteroids, ang ginagawa niya, DOC siya, or drug of choice siya for persistent asthma. Tapos, ang medical term ng sakit na ginagamot niya is status asthmaticus. So, status na asthma, gano'n. So, yung effect nitong corticosteroids is, nilolower niya yung bronchial reactivity. So, nilolower niya yung pagre-react ng bronchial parts ng body. So, kapag ginagawa niya yun, pag nalimit yung bronchial reactivity, yung pagre-react ng bronchial parts ng body or ng airways, nalolower din yung asthma reoccurrence. So, meron tayong tatlong klase ng corticosteroids, katulad ng sinabi ko kanina. Inhaled corticosteroids, tapos meron tayong systemic parenteral steroids, tsaka systemic oral steroids. Yung parenteral yung in-inject. So, yung inhaled corticosteroids, parang yun kasi yung pinakamadaling magamit or mabigay sa pasyente. Kasi nga, di ba, ina-asthma ka na, makakainom ka ba ng tubig? Siyempre, parang usually yung mga ina-asthma, gano'n, di ba? So, pag uminom na ng tubig, possible na magkaroon siya ng, ano matawag doon? Yung magsabay yung paghinga niya sa pag-inom niya ng water or mahirapan siya ma-intake talaga yung oral drug. So, ang inhaled corticosteroids, yun yung first line treatment for moderate to severe asthma. Kasi, yun nga, siya yung parang pinaka-easy na i-administer. So, ang mga inhaled corticosteroids, yung sample niyang drugs is beclometasone, budesonide, dexamethasone, flunisolide, fluticasone, tsaka mometasone. Maridinig niyo parang halos lahat sila, asone, ganun. So, ganun namin siya tinatandaan. Tapos, si systemic naman na parenteral steroids, ito yung mga ini-inject. Ang pag sinabing parenteral, yun yung mga ini-inject. So, kasama nito yung hydrocortisone, tsaka methylprednisolone. So, dun naman sa systemic oral steroids, andito si prednisolone. Tapos, nabanggit din doon na ang active metabolite ng prednisone is yung prednisolone niya. So, syempre, sa lahat ng drugs, meron yung toxicity or pag nasobrahan ka, ito yung mangyayari sa'yo or possible na outcome or indication, contraindication, mga ganun. So, dahil kapag nasobrahan ka ng corticosteroid, magkakaroon ka ng osteoporosis. So, kapag sa ICS naman or yung inhaled corticosteroids, oral pharyngeal candidiasis, yung mouth sores sa mouth or sa pharynx. Or, pwede ka magkaroon ng Cushing's syndrome. So, yun. Tapos na tayo sa corticosteroids, let's proceed to the anti-IgE. Si anti-IgE naman, meron lang siya nag-iisang drug. So, andito si omalizumab. Omalizumab. So, si omalizumab, ang brand name is Xolair. So, ang use niya is to lower the frequency and severity of asthma attack na kailangan din si omalizumab, kailangan din niyang maging co-drug or co-conjunction si corticosteroid. So, ang mechanism of action naman of anti-IgE is, it binds to human IgE, kaya nga siya anti-IgE, tinatanggal niya yung effect ni IgE para malimit yung release of mediators of allergic response kasi si IgE, it's for allergy. So, kaya malaki yung kapag tinatandaan namin siya ganito. Ano ba? IgE. Allergy. Yan. So, si IgE, hindi ko alam kung nakikita nyo. IgE, so E, allergy. Yun, hindi ko alam kung baliktad mo siya nakikita. Kasi yun, ganoon naman siya tinatandaan. Kung para saan ba siya. Pero, syempre, kakaulit, natatandaan mo na siya talaga. So, after ng anti-IgE, meron tayong mast cell stabilizers. Under pa rin siya ng anti-inflammatory agents. So, ang drugs under mast cell stabilizers is yung cromolyn sodium, lidocaine sodium, tsaka ketotifen. Ang side effect nitong mga drugs na to is throat irritation, cough, dry mouth, chest tightness, and wheezing. Kasi, ang mga mast cell stabilizers, usually, ano lang sila? Inhalation. Sa pagkakaalam ko. Correct me if I'm wrong, please. So, ang mechanism of action ng mga mast cell stabilizers is, sa airway, in-inhibit niya or ni-stop niya totally si cough. Sa mast cells naman, binablock niya yung degranulation. Therefore, naglo-lower yung mediator release. Tapos, nagkakaroon ng bronchodilation. Kasi, yun nga, na-inhibit yung pag-release ng mediator. Tapos, eosinophils naman, ng effect ni mast cell stabilizers, ini-inhibit niya yung inflammatory response to allergens. So, katulad dun sa parang anti-IgE, kapag na-inhibit yung response sa allergens, ibig sabihin, hindi magiging parang less sensitive ka sa allergens, anti-allergy, parang ganun. Less occurrence ng pag-uubo mo. So, ayun. Tapos, ayun na. Andun na tayo kay leukotriene pathway inhibitor. So, isa to sa mga anti-asthma drugs na it prevents yung exercise-induced asthma or antigen-induced bronchospasm. Yung kapag sobrang na-exercise ka, hindi ka na makahinga, ganun. Or, yung kapag, di ba, nag-allergy ka, so, nahihirapan ka huminga. So, ito yung mga parang tina-target nitong drugs na to. So, ito, ginagamit din siya. Yung leukotriene pathway is also used for prophylaxis of asthma in children. So, ang side effect ni leukotriene pathway inhibitors is tinataas yung serum hepatic enzymes. So, yung serum hepatic enzymes, ito yung sa liver mo. So, syempre, doon siya na-metabolize. So, yung serum hepatic enzymes na nag-i-increase. So, yung example ng leukotriene pathway inhibitors, ito, very, very common siya nung nag-i-intern ako sa hospital and sa community pharmacy. Ito yung lagi nilang kinukuha. Si Zafir Lucas at si Monte Lucas. Ang hindi ako nagpa-promote, pero ang pinaka naririnig dun sa pharmacy is si Monte Lucas. So, ang side effect naman nitong dalawang to pag nasobrahan or sa pag nagkaroon ng contraindication is Churg-Strauss syndrome. Ito yung parang systemic vasculitis, para siyang tumor na nagre-release ng, or nag-stimulate na release ng mucus, therefore, nagkakaroon ka ng ubo-ubo. So, under leukotriene pathway inhibitor naman, meron din doon na 5-lipoxygenase inhibitor at si Zileuton ito. So, ang mechanism of action nitong dalawang to is, syempre, binablock niya yung leukotriene synthesis. Therefore, nai-stop yung pag-uubo and pag-constrict ng bronchioles. So, yung long-acting sympathomimetic drugs naman, or LABA, ito yung naririnig natin kanina nung inibigay ko yung classifications ng asthma. So, long-acting sympathomimetic drugs or long-acting beta-2 antagonist. Ito yung for quick relief. It's not for quick relief kasi long-acting siya. But, yung duration niya is mas mahaba kaysa sa SABA or short-acting. So, yung duration of action ni LABA is up to 12 hours. Kaso, ang side effect niya, tachycardia, tremor, hypoglycemia, ganun. Ang common drugs under LABA is salmeterol, formoterol, and indacaterol. So, dun sa tatlong yon, si salmeterol, partial agonist lang siya. Si formoterol, full agonist naman siya. Si indaketerol is ultra long-acting, also used for COPD. Then, we also have combination drugs for asthma. Ito yung mga drugs na usually ginagamit kapag sobrang severe na or hindi siya makaya ng iisang drug lang. So, kailangan niya ng kasama, kailangan niya ng partner. So, usually, si salbutamol plus ipratropium or combivent yung running niya. Tapos, si fluticasone and salmeterol or seretide and budesonide plus formoterol, Symbicort. So, itong mga to, inhalation ko yata sila nakita. Or kung hindi inhalation, the-inject. So, it causes bronchodilation silang lahat. So, usually, ang asthma, it happens for or with people who are less than 50 years old. Tapos, ang difference sa chronic obstructive pulmonary disease is, ang chronic obstructive pulmonary disease happens with people who are more than 35 years old. So, under COPD, meron siyang cough with mucus, or also called as, or described as, smoker's cough. Kasi kapag nag-smoke ka, nag-increase yung production of mucus. Then, under asthma naman is cough by airway inflammation kasi yun talaga yung pathology ng asthma. What they have in common is wheezing, chest tightness, and shortness of breath. So, kapag sinabi nila na, uy, natakay ka ng asthma pero meron kang mucus, usually, it's COPD. So, ang physician ang magda-diagnose. So, under COPD naman, or chronic obstructive pulmonary disease medication, merong 4 na categories. So, category A, low risk and low symptoms. Ang gamot sa kanya is SABA. Category B, low risk, medium symptoms, LABA. Long-acting kasi medium na yung symptoms niya. So, ang C naman, ang category C, high risk, low symptoms. Meron siyang kasama na ICS plus LABA or inhaled corticosteroids plus long-acting beta-2 agonist. Tapos, si classification D naman, high risk, medium symptoms, ICS plus LABA din. So, ang ano niya, low risk, low symptoms A. Low risk, medium symptoms B. Tapos, high risk, low symptoms C. As high risk, high symptoms or medium symptoms D. So, yun. Pa-increase siya na pa-increase.
Hi! So, dahil dun tayo sa respiratory drugs, we will also tackle cough. Kasama siya dun sa mga tinakal namin for midterms. So, cough is caused by stimulation in PLTB. So, ang nilagay ko is kasama doon yung trachea and bronchi. So, cough is either voluntary or involuntary reflex to remove foreign materials from our airways. So, ito yung parang defense mechanism ng katawan para matanggal yung kung meron mang naging foreign invader sa airways natin. So, yun. Meron 2 types ng cough. We have non-productive and productive. So, non-productive is dry with no phlegm. Ito yung dry cough. Then, the productive is the wet or phlegmic cough. Diba? Kapag pumunta ka ng pharmacy, tapos sinabi mo, Miss, yung pang-ubo, ganun. Tatanungin ng pharmacist mo or ng pharmacy assistant, is it po dry cough or yung merong phlegma? Kaya, kung maririnig nyo rin dun sa mga commercial, dry cough, ganyan. Or, ubong may phlegma, tanggalin natin yan, ganyan. So, alam nyo na yung mga commercial na yun. So, ang cause ng non-productive or ng dry cough is usually allergy at saka ACE inhibitors, yung gamot, side effect siya ng ACE inhibitors, and asthma. So, sa productive or wet cough, or yung ubong may phlegma, ang causes niya usually is colds, infections, lung disease, smoking. So, ito yung parang secondary na sakit mo. So, kung pag sinisipon ka or nagkaroon ka ng colds, usually meron yung phlegm, di ba? So, magkakaroon ka rin ng wet cough. So, drugs used for cough treatment, ano na lang siya, 4. Antitussives, mucolytics, expectorants, tsaka antihistamines. So, ang antitussives, meron tayong opioids. Ang under doon is codeine. Ang mechanism of action niya is to suppress cough in the central nervous system or the CNS. So, ang side effect niya, constipation, respiratory depression, tsaka drowsiness. Nakakaantok ang opioids, ang antitussives. So, usually, ang duration of action niya is 6 hours and contraindicated to patients who are asthmatics or children. So, bawal siyang ibigay sa children, yung opioids. Halata naman. Since bawal yon, nagkaroon ang pharmaceutical industry ng another alternative, which is dextromethorphan. Ito yung sikat na ngayon. So, ang duration of action ni dextromethorphan or duration ng effectiveness niya is 6 hours ulit. Same ni opioid, pero much safer. And, ang side effect lang niya na different is it may cause dysphoria. So, number 2, mucolytics. So, under mucolytics, we have acetylcysteine, bromhexine, ambroxol, bromhexine or ambroxol, carbocysteine. So, 3 yon. Actually, 4. Pero si bromhexine tsaka si ambroxol kasi same sila ng mechanism of action. So, si acetylcysteine muna, ang mechanism of action ni acetylcysteine is, it is a mucolytic that acts on the sulfuric group, which therefore decreases the viscosity of mucus. Diba mucolytic, dinedecrease niya ang viscosity or pagkalapot ng phlegma. So, ang side effect nito is bronchospasm, drowsiness, nausea, vomiting, rhinorrhea. So, it is used as an antidote for paracetamol poisoning also. Tsaka, pwede rin siya maging antioxidant daw. So, ang tandaan, mucolytics is, it dissolves mucus viscosity. So, yun. So, si bromhexine and ambroxol naman, ang mechanism of action niya is depolymerization. Tapos, nagkakaroon ng liberation of lysosomal. Tapos, nagkakaroon ng thinner mucus lining. Ganun pa din, na it dissolves mucus, which therefore decreases the viscosity of the phlegm. So, yung si carbocysteine naman, same as acetylcysteine ang ginagawa niya. So, ang same si acetylcysteine and si carbocysteine. Tapos, si bromhexine, kas parehas niya ni ambroxol. So, doon naman tayo sa pangatlong classification ng drug, si expectorant. Under expectorant, we have guaifenesin. So, ang side effect lang ng guaifenesin is drowsiness, stomach upset, rash, and nausea and vomiting. So, nakakaantok usually ang mga cough medicines. Kaya, nagkaroon ng issue before na ginagamit nila ang OTC cough medicines na pampatulog lang. Medyo nakaka-addict siya kasi